Caseworkers are stretched thin, balancing high caseloads and endless paperwork. But with SpeakRight, documentation doesn't have to mean burnout. SpeakRight's Protective Services transcription cuts paperwork time dramatically, so you can meet deadlines, reduce overtime, and focus on what truly matters, the families you serve. With SpeakRight's free mobile app and desktop platform, caseworkers can capture detailed narratives anytime, anywhere, with just one tap to upload. SpeakRight is proven to lower stress and turnover, helping agencies retain dedicated staff while improving case quality. Don't let documentation slow you down. Let SpeakRight do the heavy lifting. Visit speakright.com/imprint to see how SpeakRight can transform your agency today. That's SpeakRight, SpeakWrite.com/imprint.
Hello and welcome to the Imprint Weekly Podcast. I'm John Kelly, Senior Editor of the Imprint, a daily news site covering child welfare and youth justice around the country. You can read all of our coverage at imprintnews.org or check us out on Facebook or Twitter at the Imprint News. You can also sign up on our homepage for our free weekly and monthly newsletters, and for professionals in child welfare and youth justice, subscribe to our Youth Services Insider section for a closer look at news on business policy and practice. The Imprint Weekly Podcast is also a member of the Safe Camp Audio Network. You can check out our show page and all of Safe Camp's other great podcasts at safecampaudio.org on the web or at Safecamp Audio on social media. On this episode, Zach Laris, founder of Bolder Horizons and author of the great new policy blog called Child Welfare Wonk, joins us to talk Medicaid, child welfare, and the intersection of those two things. Now, I wanted to have Zach on because, as we discussed last week on the headlines edition of the Imprint Weekly Podcast, there's a lot going on in terms of federal spending on Capitol Hill right now. We have the president's budget request for 2026, which is still not released yet in its full form. We expect that pretty much any day at this point, which will get the ball rolling on actually hammering out like annual appropriations. Then you've got the bigger pizza pies about tax cuts and spending over a 10-year period that relate to the reconciliation bill that Congress is starting to move. So I wanted to have Zach on because at the time that me and him had this conversation, we had just gotten the news that early budget reconciliation plans included some instructions to the House Energy and Commerce Committee, which is very powerful, to find $800 billion in cuts over 10 years. And that was simply impossible without major changes to Medicaid. Zach is a whiz at all things federal spending when it comes to child welfare, so I wanted him to join us to just sort of lay out exactly how big the stakes are for child welfare when Medicaid cuts are on the table. So in the ensuing weeks, since we've had that conversation that you're about to hear, Congress has begun to indeed move a reconciliation bill forward, and it does include pretty significant changes to Medicaid. I will say that the biggest cuts being discussed, the biggest changes to the program itself, ones that would have impacted kids and probably parents the most, were not included, but we are also not done with this process yet, right? The bills have moved through some committees. We're definitely not anywhere near the end of this process yet. So it's kind of wait and see on the extent to which Medicaid comes into the crosshairs here as they decide how to proceed on this reconciliation bill. So Zach and I break down sort of all the ways in which Medicaid touches on child welfare. And then in our next guest interview with Alex Briscoe, which is going to come out on June 2nd, we're not doing a Imprint podcast on Memorial Day. We are going to kind of go beyond the basics of Medicaid and really explore more about the program and how Alex and lots of other people want to rethink the way that it supports mental health services and supports for children and youth. So without further ado, here is our conversation on Medicaid with Zach Laris. All right, we are joined today by Zach Laris, who last time he joined us back in 2021 was Director of Federal Advocacy and Child Welfare Policy for the American Academy of Pediatrics. Now he is doing his own thing. He's the founder of Bolder Horizons, which is a nonprofit startup creating educational materials for policymakers and their staff. And he is the author of a great new blog called Child Welfare Wonk. Zach, thanks for joining us on the Imprint Weekly Podcast. How you doing?
Doing great, John. Thanks so much for having me.
Let's get a call out to the blog right away before we get started. Where can people go to find you, and what can they expect there?
Thanks so much. Yeah, childwelfarewonk.com. Every Monday, we put out a weekly policy newsletter specific to federal child welfare policy. So, analysis of the latest data, explanation of the news in context. So, what's going on, say, at HHS or the Administration for Children and Families or Congress, but with a focus on what does that mean for child welfare policy.
I'll say two things about it too, as one of the few people who's been writing regularly about the very minutiae of child welfare policy and funding for a long time. It's nice to have another person doing it, and I like that you have made it fun and made it your own. It's very serious stuff, but you put some personality to it. It's fun.
I appreciate that. Yeah, I'm a big believer that we should take the work seriously and that we don't need to take ourselves seriously.
There
So
you go.
recognizing that we're digging into data and stuff, it's helpful to just be able to have a little bit of levity there too.
Well said. Absolutely. So, rules on this podcast, as Zach knows, as a returning guest, is that he has to give you folks a favorite. Categories are TV, show or movie, musical group, sports team, or book. I went back and looked. He gave me Grateful Dead last time, so that's out. You got to give us something new. What do you got for them, Zach?
Let's see. I'll give you Grateful Dead last time. I'd say other favorites in the category of music. I'm a huge fan of Fish as well. And then also a very eclectic taste. So really into all kinds of hip hop, especially like 90s and 2000s stuff. Love the Wu-Tang Clan.
There you go. They're going on tour. You should go see them.
Yeah.
For allegedly the last one, but you got to be dubious with we swear this is the last time in any band.
The last one until the next last one.
Exactly.
Yeah,
exactly. So I've had Zach on now. We can have him on any week, really, but I wanted to mostly talk Medicaid with him, which we'll get to, and then maybe a little Family First Prevention Services Act. But let's just quickly start with the recently passed continuing resolution, which you did a great breakdown on the blog about. So on the top line, no real cuts to even like the discretionary child welfare programs here, but you noted a few concerns in regards to inflation and to earmarks. Can you talk a little bit about that?
Yeah, so we've got now several years in a row of level funding for most discretionary programs on the domestic side. So folks may be aware after the negotiations on the recent continuing resolution, we've got, some increases on the defense side, some reductions on domestic programs. A lot of that, most of that comes from the elimination of so-called congressionally directed spending, aka earmarks. So on the child welfare side, a couple things at play. One is that, as folks may know, most of the big funding in federal child welfare policy comes from mandatory programs. So these are the things where you don't have to go back to Congress to sing for your supper every year.
Yeah.
This is the standard like plug and chug stuff that continues, like the Title IV program to pay for foster care, for prevention services, adoption assistance, et cetera. But there are some, key programs and some pieces of, say like part of Title IV-B is discretionary and part of it is mandatory. Programs like the Child Abuse Prevention and Treatment Act are discretionary programs. And so while you have level funding for a few years, there's a few things to be aware of with that. One, of course, is the power of inflation, right? I mean, everybody's been living through that. It's the top of the fold for pretty much every publication for years now. So we've seen inflation eating into people's paychecks. It's also eating into the purchasing power of federal programs. And so that means that even though we've got level funding, having 3 years in a row of that same line means you're really seeing a reduction in the purchasing power of those programs, many of which are, not massively funded to begin with. The other things to note here, too, are, a continuing resolution, there's a few other things that happen. One is you get a bit of a lock-in effect. So there's not a lot of opportunity for thinking in a big proactive way for Congress to say, what should we be doing? What could we revisit here? Typically, the appropriations process is a chance to check in and say, how do we feel about this? Is this working? Is this getting us what we thought it should or would? And if not, let's change tack. But that's not going to happen here. You've got locked-in policies, going back to the prior administration. There's also tremendous flexibility in any continuing resolution. So a full-on comprehensive funding bill gets really detailed into the minutia, even outside of things like earmarks, to say specific amounts of funding for specific programs. A CR is much more high level. It's, hey, this particular, part of this agency gets this budget. And that means there's a lot of room to move funds around. And so you can't necessarily assume that everything will get the exact same amount, even if the funding is level.
I cannot recall, and I've been covering this stuff since basically about 2001, a year where we actually had continuing resolutions all the way through the year, which we are now basically certain to have with this.
Yeah.
Am I right about that? I'm sure it could have happened at some point, but it feels like at some point they eventually get some kind of spending deal in place, whether it's an omnibus deal or something like that. Might not be what everybody wants, but it's a little bit more than this.
I don't remember top of my head the last time that we had a full year CR, but it's something that on a bipartisan basis Congress tries to avoid because they take a lot of ability to have oversight and directive from Congress.
And it feels like particularly stark as you're seeing a pretty controversial and charged discussion about what the Trump administration is doing with Doge and cutting back itself from the executive side, that these guys aren't going to pass a budget, which is kind of a, I don't know, strikes me as kind of statement, quite a statement as that's ongoing,
Yeah, it'll continue to provide substantial flexibility to the Trump administration to make choices about where they want to move funds to.
Yeah. So, for better or worse, the resolution of this year's fiscal picture by just doing this continuing resolution all the way up to the end. I guess I should have mentioned that is the deal they struck. The fiscal year ends in September, and so does the CR. So we're done. That dispenses of this year. And with that set, the stage is kind of there for an epic battle now over an actual spending package and budget for the next fiscal year, but not even that, just a framework for the next decade. And so the House has already moved forward with a budget framework that sort of tells the various appropriations committees what they need to do. And it includes for the Committee on Energy and Commerce, I'm just going to read this quick. The Committee on Energy and Commerce shall submit changes in laws within its jurisdiction to reduce the deficit by not less than $880 billion for the period of fiscal years 2025 through 2034. And that very wonky piece of legislative text is why I wanted Zach here, because I think it's safe to say, with all the analysis that has happened since that came out, it pretty much only could happen what they described there with a very, very sizable cut to Medicaid on the order of, several $billion every year for 10 years. Is that fair assessment?
Yeah, definitely. The Nonpartisan Congressional Budget Office has taken a look at, what programs are in energy and commerce jurisdiction to provide an analysis and say where could potential reductions come from in line with this direction. And the overwhelming majority, well over 90% of that, would be the Medicaid program, because the math just doesn't line up. It really is, it is the huge program in that jurisdiction and by orders of magnitude.
Right. So I thought this was a good time to let's go kind of incrementally through Medicaid and sort of talk through its implications and the way that it touches child welfare. Because on this podcast, we talk a lot about, our listeners are very familiar with the terms 4E and 4B and CAPTA funding and things like that are very hyper specifically about child welfare. I'll welcome your opinion on this, but I would venture to say that Medicaid is actually more important in the totality of financing child welfare than any of those, including 4E. Do you think that's true?
I think you could certainly make a strong argument in that direction. Yeah. I mean, Medicaid really is a huge part of every state's budget. So, I mean, even beyond child welfare policy, it is a major driver of all of health and human services policy. It's really core. If you think about what do, say, children and families who are in or at risk of entering or have had contact with the child welfare system, what do they need? So much of that comes down to services. And where the rubber meets the road is who pays for it? How do you get it? And Medicaid is a huge component of that. It is critical.
Yeah, so we'll go through kind of the different ways that is the case. But before we do that, let me not assume, Medicaid is a very complicated system. And so let's make sure people understand exactly how it works. Can you give kind of just a top line explanation of the way the money, I think most people know it's healthcare, it's health insurance for people mostly that cannot afford private insurance or don't get it through their employer. So give people a top line explanation of the way the money works and the ways in which Medicaid is delivered to people.
Yeah. So Medicaid, kind of analogous to, say, something like Title 4E, it's a state-federal partnership program. And so it's a way to pay for health services. So, what that looks like functionally on the ground is a provision of health insurance to, children and families typically with low incomes. Historically, Medicaid has really had an emphasis on particular eligibility categories. So, in the past, it was not enough simply to be very low income. You also had to have, say, a particular type of disability or be a parent to be able to access the Medicaid program. With the Affordable Care Act, that was the first time that the Medicaid expansion became an option for states to be able to also offer Medicaid coverage to adults without dependent children up to a certain poverty level. And so that provides some basic level of care. And Medicaid is really key in particular for children. As an insurance program, it covers nearly half of all children. It covers over half of all births in this country and is really vital to that work. And so, and the last thing I'll say is in terms of like the flow of resources and things, for folks that are in the weeds on something like Title 4E, it's an analogous process where states, put the money up front and then on a quarterly basis get reimbursed by the federal government to cover their expenses. But it's an open-ended entitlement program based on the population and what the costs are. And then the states have a share of that they have to cover and the feds cover the rest.
Right. So it's basically federal money coming in to help each state pay for the provision of healthcare services, and that would include mental health services and a lot of other things other than your doctor visits, to some extent at the size and scope that the state would like. You could have a pretty small Medicaid program, or you could have a pretty expansive one at this point. Fair to say?
That's right. Yeah. And I mean, you mentioned, mental health and substance use disorder treatment services. The other thing that's really critical, and I think where you have a lot of intersection with the child welfare system, is Medicaid is the primary payer in this country of mental health and substance use disorder services.
Yeah. So that segues nicely, because I think my first kind of like, as you take it down the road, right, in terms of like the continuum of child welfare, how would you describe the role that Medicaid plays in keeping children and families from ever having contact with the system? I think you just started. Those are two pretty sizable ways, right?
Absolutely. I mean, if you think about some of the core drivers of what brings children into the child welfare system, we know from the data, from the research, it's very clear one of the big drivers of child welfare involvement is unmet parental mental health or substance use disorder treatment need. It's a big reason, in particular for infants and very young children coming into care. And a key thing that Medicaid is able to do is provide access to treatment for parents so that they don't get to that point of crisis, so that they can remain safely together. And also youth mental health service access. So we know for older youth, and there's been some recent data about this too, oftentimes we see, teens coming into the foster care system, not necessarily because of abuse or neglect, but because of a need to access mental health services. So oftentimes when Medicaid can provide that access, that prevents the need to come into foster care as a way to access, say, deep end residential services that are otherwise inaccessible for a family.
Yeah, that's a good call. I'll link people to a story that our reporter Sarah Tiana wrote about that very thing in Texas last week. Well, last week when me and Zach are talking, I'm not sure when this will come out, but it's a good story and it really speaks to the study that Zach's referring to, which really found that about, it could be as high as like 5% or even more of entries into foster care are attributable to what they call relinquishment, right? Coming to the front door. We had Ohio Medicaid, I think was one of the first interviews I ever did on the podcast, was the Ohio Medicaid director coming on and basically talking about the way they were going to try and rewrite Medicaid, partly because they realized their counties were largely just instructing people who are in that crisis with their kids about mental health issues, put them in foster care, was like the state solution, which none of us want. Like, nobody would like root for that. Okay, so that's sort of prevention. How about for children who end up in foster care? How does Medicaid touch their lives?
Yeah, that point about, entry into care and access to services is a great segue, because the reason that happens is that Medicaid covers at least 99% of children in foster care. So through multiple different pathways, there's a lot of sort of wonky back-end details, but functionally what ends up happening is almost every child in foster care has Medicaid coverage to pay for all of their health services.
Right. And that is, if I'm not mistaken, categorical, right? I guess we didn't talk about this at the outset, but there's like parts of Medicaid where states have a choice.
Yep.
And there's parts of Medicaid where it's like you have to do it. And this is one of those, right? You have to offer a path to coverage for kids in foster care
who are Title 4E eligible.
Right. Okay.
So, and then most states just, cover all kids through either, other pathways. And so that's where it gets there's some different approaches and strategies there, but functionally, yes.
But the net effect is almost every child who's in foster care in this country is Medicaid eligible
Yes.
and getting covered by Medicaid through their states. Okay. And then as part of Obamacare, the Affordable Care Act sort of took that categorical eligibility for the youth who are in the system and expanded it out basically to match what any kid would be able to expect from their parents
Yes.
through age 26, right?
Yeah, so under the Affordable Care Act, one of the most popular provisions of the ACA, if as you poll people on specific components of it,
Mhm.
is one that many people are familiar with, which is up to age 26, you can, as a dependent, be on your parents' health insurance. And the thinking makes sense there, right? Like you're kind of early in your life, you're going to school or you're starting your career, you're looking to begin your family. It's a chance to kind of give you that stability and foundation. And so the same idea applies here for young people who age out of foster care. The recognition is, okay, if we have you aging out of a system and we've failed to provide you that kind of permanency and connection to a family where you'll have that access to dependent coverage, then what we ought to do is provide you this guaranteed access to Medicaid. And so for some time now, that's been the case within the state that you aged out of care in. And recently, Congress also passed a new law that has taken effect now, so that that's the case across the country. So even if young people say move across state lines, all the stuff that you often do in that age group, right? You might, you want to go to school somewhere else, or you
Yeah.
want to go to where the work is. Now you don't have to worry about staying somewhere because you have your health insurance in the state you were in the system with. You can go anywhere and you'll have access to Medicaid coverage.
And I don't know if you caught this GAO study that came out I think it was last month, that basically tried to look a little bit at this, like how
Yep.
many older youth are getting covered by Medicaid. And it was honestly a little annoying because it lacked a denominator. So it was really good. You had no context for like what percent of potentially the
Yes.
universe was getting in. But I just back in the envelope, I think it was 112,000 youth that they had identified. And when you just try to think of, okay, what would the likely number of youth or young people, young adults at that point, between that age of 18 and 26 who would use Medicaid be, that actually kind of checked out as like a very high amount to me.
Yeah, I mean, the GAO report points to definitely some gaps and need to be
Mhm.
able to make progress in providing access to information about coverage. So I think there's still room to grow. We know there's, roughly about 18,000 young people who age out of care every year.
Right.
And so kind of matching those up, that's right. Like, it's good to see that the policy seems to be working. The thing that seems like an opportunity is really making sure there's clear communication about access to those benefits and how to go about doing that. And oftentimes those who are falling through the cracks, it's for reasons like, changes of housing and address where things are getting sort of lost in the shuffle in terms of outreach from, say, the Medicaid agency to say, hey,
Yeah.
it's time to renew your coverage.
Yeah. So that's actually kids in the system, and then for some who have aged out of the system, how Medicaid impacts them. For the actual child welfare agencies, right, whether that's a county or a state or whatever, what other role does Medicaid play outside of just simply the provision of health coverage to, their clients, so to speak?
A key part of this is placement stability, right? If you think about that, we're sort of walking through that continuum of care, right? We started with prevention and then we're talking about foster care. The next step there, that we know the gold standard, the evidence tells us what works, is kinship care. And what do we know about kinship caregivers? They tend to be older, they tend to have lower incomes, and they tend to not have planned ahead to assume that they were going to, say, raise a grandchild or a niece or nephew. And so oftentimes you're stepping into a child or young person's life, because you love them and care about them and want to provide that stability. But that wasn't something that you had the opportunity to plan ahead for financially and have some extra reserves. And say if you're an older adult, you might be, say, on Medicare, that there's not an option for you to use your Medicare coverage to help a dependent. And so what Medicaid does by covering the child is make it so that grandma doesn't have to be sitting at the kitchen table every night worrying about how am I going to pay for all these medical bills or how am I going to go get some insurance. Grandma just gets to be grandma, and you can focus on Medicaid taking care of that coverage. Beyond that, I would, say, like, so that certainly helps with placement stability. It's key to accessing those services, right? So, I mean, even if you're, beyond, say, kinship placement, even think about family foster care, the access to things like mental health services, the access to comprehensive care, and in particular, Medicaid for, under the age of 21 comes with the early and periodic screening, diagnosis, and treatment benefit, EPSDT. EPSDT is a gold standard in children's healthcare policy. It essentially means that even when say a child comes into a pediatrician's office and the pediatrician, diagnoses them with a particular condition or finds that some intervention is medically necessary, even if that wouldn't otherwise be something that Medicaid would pay for, under EPSDT, Medicaid will pay for it for a child. And so that means you've got that ability to provide access to really comprehensive coverage. And that's key to being able to help reduce placement instability by providing things like, access to the therapy that helps to stabilize a young person.
And I'm glad you brought EPSDT up, because I do think this is a good point to kind of probably make clear in our discussion that we are talking about the things that Medicaid makes possible. And let's not do that in utopia. There are definitely states and places and ways in which Medicaid stinks. You'll hear that from people. I can't get these services. Yeah, okay, theoretically it exists, but I can't find somebody to provide that. EPSDT is on paper just one of the greatest guarantees, but you routinely hear that in lots of states it's not done, right? So then they don't get it. So this is not to say by any means that the provision of healthcare through to foster youth and through the child welfare system is perfect, because Medicaid's there, but it offers the path. It's a roadway you could improve, right? That's at least at the very least.
It's a key foundation, and that promise is there. So even when there are opportunities to strengthen and expand, it provides that basis and that aspirational approach.
Today's episode is powered by Listen, a groundbreaking AI platform transforming how child welfare and other public sector providers learn and grow. Imagine being able to roll out comprehensive, secure training and quality monitoring across your entire organization instantly. That's exactly what Listen delivers to over 70 public and private sector clients. Developed by PhD academic psychologists, Listen helps health and human services agencies master motivational interviewing and other evidence-based practices. And this isn't just another training tool. It's backed by 16 years of rigorous research and peer-reviewed studies. To learn more, visit listen.io. That's lyssn.io. lyssn.io. Or follow the link in the show notes.
One more corner of the Medicaid role in child welfare I would love your thoughts on is, so we're both big fans of Child Trends and what they do. The financing survey every 2 years is really one of the backbone things now in terms of understanding how things are working. And I really thought, I geeked out on this in the podcast when it happened. The last report, they sort of cryptically noted that Medicaid as a payer of child welfare overall had really grown. And their observation was that had a lot to do with the fact that in several states, it had become a top 3 payer of congregate care services. So residential group home services for youth. And I don't remember exactly what the line was, but they basically followed that with like, somebody should really look into why, which I love your thoughts on that, because what it really said to me was, it seems likely that we've seen an increase in kind of the capacity or build out of beds and placements that are for a very acute level of care, like psychiatric facilities and things like that. But what did you make of that?
Yeah, I mean, it's a good question, because in addition to all the coverage that we're talking about at a national level, the Child Trends data you're talking about highlights that in the states where we know Medicaid is something that flows through a child welfare agency, it on a national basis is 7% of the federal child welfare spending. So it's not insignificant. I mean, that's more than, say, a program like the Child Abuse Prevention and Treatment Act, CAPTA, which I think a lot of folks would find surprising. And that can be a variety of things. I think that's right, that certainly we've seen in some states there's that kind of policy choice point. Many are trying to figure out how to make family first work on the ground, and certainly recognizing the congregate care reforms that Family First makes, and the qualified residential treatment program model and some of the challenges states have articulated in implementing that, it is not surprising to me that you might see more states going down the pathway of, say, building out a psychiatric residential treatment facility, which is a particular, term of art in Medicaid law that focuses on high acuity residential interventions for children and youth. And so I've heard anecdotally, certainly some states that are building that kind of model out. That could be part of it. And then, child welfare agencies also do provide mental health services, right? If you, have your own in-house team of, say, mental health service providers, and you're doing, say, targeted case management and other activities, that's also a way that ends up drawing down Medicaid funding through the agency as well.
Yeah. So all of this taken into consideration, you've got this looming potential for at least instructions to these appropriators to cut back on Medicaid. And even if the cuts to Medicaid end up being far less than, whatever, $80 billion a year, what do you most worry will be on the table as far as it applies to child welfare? Where do you think what we just talked about, where do you see vulnerability? Where are you most concerned about?
Yeah, I mean, Medicaid is such a significant part of any state budget that the biggest thing I would say for folks paying attention is it's easy to think about these things in isolation. And it's easy to think about, say, oh, is this particular population part of the discussion, or are we just talking about, say, work requirements over here or something else? And if you take nothing else away, it should be that all of this is interconnected. And so it is impossible to make major, significant existential changes to the Medicaid program and not have that affect the child welfare system, even if it seems like ostensibly it's focused elsewhere, because the math is just too significant for any state health and human services agency to be able to make up. And it's going to be incredibly challenging if that were the case. But it's also not a done deal.
No, but that's a great point. If I'm hearing you right, what you're saying is, even if there's nothing very specific about, like, take categorical eligibility away from foster youth, but a lot of people, or this or that, at the end of the day, if states are all going at the same time to look to fill some $200 million to $10 billion hole in their budget, there's just no chance that happens without some sort of proportional impact on smaller fish, right, in the sea.
That's exactly right.
Child welfare kind of would be, compared to the health of everybody in the state.
That's exactly right. And so, I mean, for folks that are interested, one of the things I did in my most recent newsletter is I was playing around with some of the child trends data as I've thought about, all of these different policy conversations that are happening. There's reconciliation. There's several new, initiatives from the Administration for Children and Families about reviewing programs for, say, like compliance with immigration law, and, expressly says funding through the Administration for Children and Families could be at risk. Taken in totality, it means you've got, several major funding streams that child welfare agencies rely upon that could be facing either cuts from Congress or rescissions from the administration. So I went through and did some looking at, what are the states that are disproportionately reliant for their total child welfare spending on 4 programs. So Title IV-E, the Temporary Assistance for Needy Families, the Social Services Block Grant, and Medicaid. And so found 17 states that have over half of their total child welfare spending come from those 4 programs. And so those are ones where, if you're on that list, it's, helpful to be able to look at that and say, what does this mean if we were to see some significant reductions in any of these programs?
That was a very fascinating chart. I'll make sure that's linked in our show notes. Very blown away that New Hampshire was such an outsized number 1. Although they are to bring this back to what we were just talking about, they are one of the last, what I would call, super users of congregate care. We'll talk a little about Family First in a minute here, but we used to have, I want to say, a dozen, maybe more states where 20% or more of the kids in foster care at any given time were in a group home, or they were in a residential or whatever. And I think we're just down to New Hampshire and maybe Colorado or somebody else. So, like, they're one of the last ones. And that stuff is expensive. Yep. So I guess in that sense, it's not like all that shocking. But
yes,
one element of Medicaid that I'd love your thoughts on whether or not, in a very bizarre world, this could be buoyed by a different funding picture as opposed to go away, is waivers. So states have been able for a long time to seek waivers to Medicaid to do different things, experiment different ways. I know, at least in some states and among some advocates, there's a lot of energy around the idea of trying to use waivers to really rethink, honestly, especially on the mental health side, like what it means to take care of kids, and really get away from just a full-on myopic mindset of it's a diagnosis and then it's a couch you're on and
Yeah.
then a medication you're on. I'm not like trying to talk smack about those things. Those are important things, right? Psychiatry, psychology, important. But if you ask a kid what mental health is, they're going to say it's music, it's art, it's
Yeah.
doing stuff, right? Do you think that? Do you think there's an appetite for waivers that I think you could make the case would be cost effective if we were lowering the reliance on fairly expensive medical interventions over time? But that's a tough sell at the start. So where do you see waivers like fitting into the plans either of this administration or going forward?
Yeah, I mean, first, I'll certainly will associate myself entirely with, what young people themselves have lifted up here as the need in terms of interventions. And, this isn't just something that is a quixotic idea that young people have lifted up.
No.
I previously, one of the old hats that I wore, I'm leading federal policy and advocacy on child welfare at the American Academy of Pediatrics. I was really struck just how many pediatricians and how much AAP was willing to say publicly that those are the kinds of things that really matter. Because when we're talking about children and young people in foster care, we're not talking typically about the same sort of etiology of, say, something like schizophrenia sort of emerging in early adulthood that you normally see from an organic origin. It all tends to root back to trauma, and you're not going to be able to just solve trauma with some of those other interventions. They're important, but they're a piece of the intervention puzzle, and so that's why those types of interventions really matter. I guess my question back to your question is always the appetite by who, right? Because I think certainly there are states that have an appetite to do that, and we've seen some states do some novel experimentation, and 1115 waivers in Medicaid are really a bedrock of that kind of testing new approaches in a cost neutral way. And so there's definitely interest in finding ways to do that. But conversely, we know there's quite a few states that are interested in waivers for things like adding work requirements, adding new changes to the program that could potentially have a functional impact that would reduce the number of people that are enrolled in the program. And so it's possible we could see both of those things happening simultaneously.
Yeah. You need a state to be interested. You also need a CMS. Sorry, I hate using acronyms. The Centers for Medicaid and Medicare Services. You need them to be amenable to approving them too, though.
Yes, that's right.
I guess that's the $1 million question: is will there be an appetite for that? Just to go purely political for a second, maybe it's a red state getting interested that might have a good shot at it. I know California already has a 115 waiver, so they're off and running, I think, on that. So on some of the things that we just talked about. So it has been about 7 years since the initial passage of the Family First Prevention Services Act, which I won't belabor the explanation, but the two very main caveats of it: it opened up the Title 40 entitlement, which heretofore had been for paying for foster care, paying for adoption subsidies, to services aimed at preventing foster care placements. And then on the sort of backside of child welfare, it didn't really tell states what to do about congregate care as much as say the federal government will be minimizing its exposure to that field by limiting payments for 40 payments to just 2 weeks, unless, and there were several kind of caveats to that, including, whether if you set up qualified residential treatment placements and things like that. I just wanted sort of, before we wrapped up here, because Zach was at APA when they were a very main voice in the room pushing for this. We have the vast majority of states that have an approved prevention plan at this point, meaning they can draw these federal funds down. I'd say the amount of money that's actually going out the door for that's still pretty low. How do you think this law currently is impacting the system, both in terms of the prevention, in terms of the congregate care, knowing full well as you do that it takes a while for any big federal law to take effect? It's been a while. So are you surprised by where we're at, good or bad? How do you feel about it all?
It's that old adage, right? I mean, you can't push on the string. So, I mean, you can only make so much change at such a pace. And so I think oftentimes it's easy to oversell in the short term and undersell in the long term the impact of a major law like Family First. I'd say a few things on Family First. One is, you mentioned that among the many hats I'm wearing now, one of them is building and running a nonprofit startup focused on child welfare policy. So at Boulder Horizon, the work that we're focused on is really providing analytical, educational, nonpartisan materials with the theory of the case that we want to trust smart people to be able to do the work that they want to do and help them do it. And so we want to make sure that if you're a congressional staffer, if you work at any administration at the federal or state level, if you are working in advocacy, if you're a service provider, to be able to have some foundational understanding of key federal policies, laws, how things are going. So one thing that we're in the process of doing right now is an analysis from a fiscal perspective of what's going on with Family First implementation, looking at prevention, looking at non-family placements, and looking at kinship navigator programs. And so we anticipate being able to release that this spring and are very excited to share that with the child welfare policy community, to be able to share with policymakers and others who are interested in this work, and hope that it will be a useful contribution to have some level setting and some key facts and figures that we can point to and trust in that. On the congregate care front, when I was at the American Academy of Pediatrics, we did a study that I was the principal investigator on, looking at implementation of Family First congregate care reforms. And the way that we designed that study, we did a survey of all child welfare agency directors. We also had focus groups with CEOs of congregate care providers, folks in leadership at child welfare agencies, and then a group of young people who were old enough to consent to a research study, but young enough that they actually were in a facility that while they were there became a QRTP, to really kind of stress test what we were getting in the survey data to say, did you notice any change? Like, what happened? Was this somehow qualitatively different for you as someone who this institution was serving? I'd say, the big takeaway to a person across all of those focus groups, the biggest thing that came up was the mismatch in what you need in terms of services and supports and what you have in terms of the staffing and financing model for this type of intervention. If you think about what you want for your own kid, right? If your child needed residential services, who do you want to be the person that's with them every day working? You want somebody, this is a dedicated career. They are focused on this. They are in it to win it, and they care. And this is going to be something that they do for 30 or 40 years. Who's the median person who we end up designing a job to have come in? It's somebody who is, finishing their associate's degree. This is a way station to their actual career. And so there's this big mismatch in what we're able to provide in terms of staffing. And a lot of that comes down to, the financing model for the intervention approach. We also see in a big way, there's a huge need to figure out, how do you do aftercare well? When I was at the American Academy of Pediatrics, oftentimes I got a lot of criticism from folks who, sort of would want to paint me and the organization at the time with a very broad brush to say, you just don't like congregate care. You just don't like residential. You're just saying that it's harmful to children. Absolutely not. Unequivocally, there is a key important role for high quality residential services in the continuum of care for children in foster care, period, full stop. It's vital. It's a needed part. And it's a time-limited treatment intervention. So, what do we do to reconnect you to family? Because that's what the functional purpose is to figure out, how do we help address the need that you have so that you can succeed and thrive in a family? Aftercare is a key part of that. Family First has some guidance on that, but we haven't seen that follow through in a key way that's really driving that. And so, as somebody that worked on that and cares a lot about it, I think one of the big takeaways I have is we really want to understand what's working there and what's not, so that it can actually work to get us some good outcomes. Because, to your point earlier about Medicaid, if what we end up seeing is mostly some shifting around, then I think we have some conversations to have. So as we do this analysis, I'm interested to see what we find so that we can really help inform those conversations.
Yeah, I remember for your guys' analysis came out right around the same time that a guy in New York, who you probably know, Jim Zarniak, did a deep dive just on New York. And the two kind of common threads, as I recall this, looking back a few years, was what you just said, that the aftercare requirement, because there was one, at least if you were going to be called a qualified residential treatment program and have that exemption from the just 2 weeks of federal funding, if you were going to be in a position to get more, you had to be in a model that was really taking that seriously. And there really, at that point, wasn't evidence that was happening. And then I think just also on the QRTPs, I kind of remember coming away from those two studies thinking, are things substantively different in these places getting designated QRTPs or not? You know what I'm saying? Okay, you're getting accredited, but are you really doing anything differently than you were before? Or have you changed? Is it living up to what the contours are? And that aftercare part kind of is an indicator of maybe not all the time. Yeah,
definitely. I think that's right.
Yeah. Well, look forward to, maybe we'll get you back on here again after you put your thing out in the spring, and we'll look forward to reporting on it. So Zach Laris, now of Boulder Horizons, and the Child Welfare Wonk. Check out the blog. It's a must-read now, Child Welfare. Thanks for joining us on the Imprint Weekly Podcast.
John, thanks for having me.
Thanks to Zach Laris, founder of Boulder Horizons and author of the Child Welfare Wonk blog, for joining us today. And thank you to SpeakRight for sponsoring this episode of the Imprint Weekly Podcast. The Imprint Weekly Podcast is a production of the Safe Camp Audio Network, which is a division of Fostering Media Connections. Please visit safecampaudio.org on the web or at safecampaudio on all major social media. This podcast is produced and mixed by Christine Anjoko, with music by Luke Giroux and Cyrus Elliott. If you enjoyed this episode, we would love it if you'd consider subscribing or giving us a 5-star rating on Apple, Spotify, or wherever you download your podcasts. And we'd really appreciate if you would consider supporting our work here on the podcast and in print. Small donations from our listeners and readers go a long way towards helping us grow and cover more great stories in child welfare and youth justice. To support us, it is super easy. Just visit imprintnews.org/donate. You can follow The Imprint on Twitter and Facebook by searching the handle @TheImprintNews and visit us on the web at imprintnews.org. You can always get us over email at tips@imprintnews.org. I'm John Kelly, and we'll see you next week.